don't. I've got emotional. So next we have Dr Bea Bakshi, co-founder and CEO of See the Signs, and she's going to be telling us about redefining the future of cancer.
So I just want to kick off actually following Jess's mum's really powerful story is just by a show of hands, like how many of us as people have lost someone to cancer? Yeah, whether it's a loved one, a colleague, a neighbour. Can you keep your hands up if it's the case that you've lost someone and when you heard about their cancer diagnosis or sadly after their passing, you were left with that same thought of what if? What if we could have caught their cancer earlier? What if we could have done something differently for that patient? And often you'll see from looking around the room, we often ask this question. And one of the biggest challenges we see more and more is sometimes we're stuck in thinking that cancer is a failure of medicine. But actually, if you really think about it, it's a failure of timing. And most of you might not know this, but Miles and myself, when we co-founded See the Signs, it was never actually to be where we are today. It was very much in response to a similar experience that we had with that Jess's family had when it came to a patient who actually started the trajectory of where we are today with See the Signs. So it happened all in a night shift. I was doing as a GP out of hours in A&E, where I met this patient called Joe, who had seen his GP over the course of 6 months with accelerating symptoms. And the GP did all the right things that you would expect them to do. They did tests and investigations. They started the patient on some medication as well, but he continued to deteriorate. And this is when he came to see me when he was in A&E, floridly jaundiced and actually really unwell. And as clinicians in the room will know, is we all have those patients who stay with us when we spend an entire 8-hour shift with a single patient and caring for them and spending time with their 2 kids, learning about how they were a marathon runner, what they did in their life, speaking to their wife and having to break the bad news that actually the scans show disease completely disseminated across the body, and trying to give them some hope through navigating something which is really challenging, but also most fundamentally for Joe, which took me by surprise at least, was that typically in those scenarios when I had broken bad news about cancer many, many times before that, I was used to a reaction of, why did I get cancer? Why me? And that's something that we typically see with patients. Whereas Joe was very stoic about it. Like, he had no issue about cancer. He had seen people have cancer in the past. His issue was with the fact that he had done all the right things as a patient. And what he asked me is, why was my cancer diagnosed so late? For him, he had done all the right things. He had gone to see his doctor. He wasn't getting better. He went again, he went again, he went again. And for Joe, the system failed him. And sadly, just 3 weeks after he was diagnosed, Joe died from metastatic pancreatic cancer. And at the time, I was working nationally in digital health policy as the deputy chair of the joint GPIT committee. And with my digital hat on, one is I really wanted to understand is, could we have done something differently? But how complex is this when it comes to patients presenting in primary care? And as Andrea said, is this an isolated case or is it much bigger? And we heard from Miles earlier about the data and the challenge. I really think, as much as I love general practice and I love being GP, it's really, really hard to do cancer well in general practice. And what I want to show with you is this is similar to Joe's presentation when we think about it. And when patients come into general practice, you might see this, a 60-year-old with weight loss, abdominal pain and fatigue. And you might think along the lines of these types of tumor types that a patient might be at risk of. And it's because we're trained to think in a formulaic way with pattern recognition. But how many of you would consider the following actually pathways when it comes to this patient's presentation? And that's actually the breadth and scope of really understanding when patients are at risk of cancer, they don't present as perfect tumor types. They present with a combination of signs, symptoms, and risk factors that can present anywhere in the body at any time. It's a cradle-to-grave disease that often hides and mimics behind other healthcare conditions. So this patient with this presentation and based on national guidelines and pathways is actually eligible for all of those pathways that you see on the right-hand side. And actually, if this patient was a woman, we'd also be considering ovarian cancer risk. So you can see in a 10-minute consultation, something as innocuous as those few symptoms, actually there's vast complexity. And when you refer these patients down these one pathways, and that one pathway comes back negative, what are we truly saying? That this patient doesn't have cancer, or they don't have an upper GI cancer, or they don't have a lower GI cancer, rather than this patient themselves don't have cancer. And this is really something that becomes really complex when it comes to general practice, because the discharge comes back to us, and we have to make the decision to say, what do we do next? Where do I go looking next? And how do I find what the cause of these symptoms are? Or is it the case it's a self-limiting condition? Should I watch and wait? Should I wait till it gets worse? This complexity sits as a burden and responsibility on general practice, but also on that patient who is trusting us to the best thing for them in the challenges that we have currently in general practice. I want to share a couple of scenarios with you for the clinicians in the room, but also non-clinicians, given the fact that you commission cancer services, just to show you some of the complexity. So as specialists working in cancer, please feel free, and I'll just read this out to you as a scenario. An 11-year-old boy presents with a rash. His mother noticed a rash developing on his feet and lower legs. He's noticed it just a couple of days ago. He is otherwise well, with no other symptoms. Examination is unremarkable. So this is an afebrile. There is no neck stiffness, no photophobia, and his observations are stable. What would you do? So if you shout out to me, we've got A, B, C, D, or E. Don't be shy. We've got a room full of cancer experts, guys. So we've got E. Anyone else? This is. I know this is a cancer conference, but what would you really do in clinical practice, or what would you expect to do? Sorry, a bit louder. Brilliant. Any other options?
As a non-clinical person, we had an incident just a few weeks back, and we had someone come to reception and just turned up among the child with rash, and we're trained just to call ambulance straight away, and actually it was a good job we did, because they did have awareness as well. So, I mean, as a non-clinical person, we would just ring an ambulance, we would, if someone presented with a rash like that.
Thank you. So with this particular scenario, it is a referral immediately for hospital for any pediatrics. The key case here is it's an afebrile child that you're not querying meningitis on. But most people actually, when we do this in wider audiences, you'll find that will consider other options. Going to another case is a 65-year-old woman with discharge. So this woman presents to you with a 2-week history of visible hematuria. She denies any other symptoms. Examination is unremarkable. Blood tests are requested. And, sorry, it's meant to say 65-year-old woman with hematuria, so apologies there. So she presents with visible hematuria. Blood tests are requested, which shows an iron deficiency anemia. So 65, visible hematuria, iron deficiency anemia, urine sample confirms visible hematuria, and there's an absence of infection. Which cancers is she at risk of? What would you do next? So some of these things you can see is just to show the complexity that general practitioners face in a 10-minute consultations. And for the commissioners in the room, you can see how complex it is when pathways don't serve patients or serve primary care in the way that matches how patients present in the complexity of different signs, symptoms, and risk factors rather than perfect tumor types. So this patient, just to highlight to you, is at risk of endometrial cancer. So any patient with visible hematuria above a certain age should be evaluated for endometrial thickening, for renal and bladder cancer, but also for iron deficiency anemia. Actually, for her, the highest risk of cancer actually is colorectal, given her age profile and the fact that she's got IDA. So understanding the complexity of having to investigate all of them increases the workload, but also the burden that we often see in general practice. I'm not sure actually, Miles, if you presented this, but just curiosity, how many cancers does an average GP diagnose in a year? Any idea? Any other ones? 5 over there. It's not a lot, is it? So they diagnose 8 new cases of cancer a year. So if you think about a GP sees about 40 patients a day, so about 200 patients a week, 8 new cases really isn't a lot. And 1 rare case in a career lifetime. So that would be a pediatric cancer, a sarcoma, a brain tumor. When we think about this, and potentially controversial statement I'm going to make, is if there was, right now, we don't have specialists who diagnose cancer. Oncologists are treatment specialists. So when we take something like cancer and we think about the ability to put it in the hands of primary care practitioners who just don't see that much cancer, would we do this in any other specialty without giving general practice the tools or the technologies or support to do that? Would we expect a surgeon to do surgery if they had only done 8 cases per year? Would we expect an oncologist to treat a cancer if they'd only treated that cancer 8 times in the previous year? And some of these things we need to start asking ourselves as commissioners, are we giving primary care? And there was questions today about funding and investment in primary care. And we really need to consider if primary care and patients are presenting, I think about 90% of clinical contacts in the NHS happen in primary care. Are we giving primary care the tools and technologies to make the best decisions if they just don't see that much cancer? When you look at it as a percentage of workload, it's less than 2% of the workload. It's never going to change because whilst 1 in 2 people have a lifetime risk of cancer, actually the burden of cancer on a day-to-day basis is just not that high. So when we have to consider how we improve the front door to cancer detection, we really need to ask ourselves that how do we improve primary care, but make sure that primary care isn't carrying the burden? Because all of us, potentially as clinicians in the room, will have that one patient that sticks with us, but we know if we went back in a 10-minute appointment, would we have had the luxury to go through all their medical records? Would we have had the luxury to actually deliver continuity of care in this current climate of the NHS? Would we have had the luxury to be able to have access to all the diagnostics and opportunities that are afforded to in secondary care that often we don't have in primary care? And colleagues on the panel earlier talked about access to diagnostics and so forth. And when we think about that and we think about why we started the journey at See the Signs, and just to say is that initially we actually just set it up to give it to someone else to take forward. And we found no one was really interested and thought it's too much of an uphill battle or too much of a fight to go forward with when it comes to thinking about implementing anything in primary care. And now we have 10,000 users across primary care, which just shows that primary care is crying out for tools and technologies and investment to improve it. But one of the key things that I think a lot of the people today talked about, which gives us all solace, is the fact that how can we move that burden when we know the realities of primary care, but help to make the invisible visible when cancer does hide in plain sight? How do we give you the assurance that when you are risk assessing a patient in See the Signs, we're assessing a patient actually head to toe? So any risk assessment, we will check head to toe for cancer, rather than you thinking it might be this tumor type and going down a certain pathway. Alongside that, how do we move fast? So primary care moves very fast. Anything that takes longer time means that it's unlikely for primary care to adopt that, which is why this works in 60 seconds, but at the same time, any new technologies or innovations really have to work within the constraints of primary care. The next thing is about second guessing. I, as a GP, often used to wake up at 3 o'clock and think, oh, I didn't organize that test, or I need to do something, and I'd make a note on my phone very quickly in order to do that the next working day. I don't know how many of you have ever had that feeling. How many of us want to go home without that feeling, knowing that actually there are systems in place and safety in place that can do some of that work for us? And that's really key, that risk doesn't go home with us, it doesn't go on annual leave with us or on our sick leave. Actually, there are systems and processes in place to manage that. And colleagues earlier actually talked about it, Bushra and Ali, around safety netting, and that's really critical on that side. And also, you know, systems have to work for you. So one of the key things when we went into areas and we found, just to say also, is majority of the referral forms across the country, really interesting, aren't necessarily NICE compliant, aren't necessarily being updated or reviewed, haven't got a good quality control mechanism to them, and yet they will dictate who gets through the front door. A lot of the work we do is saying, how do we fix the front door? How do we give GPs access? How do we give GPs peace of mind? But how do we also automate the pathway end to end so it's seamless for the patient, it's seamless for primary care? And actually, if a GP wants to refer a patient, this patient isn't going to receive a downgraded referral or a rejected referral. So in See the Signs, that just doesn't happen because we work at a system level so the system can work for you as GPs. And that's really, really critical for primary care. Again, not talking just about See the Signs, but really asking you to consider any innovation you choose to implement has to think about following these types of rules when it comes to patients. And in that vein, we talked a lot about how we want to be as led by yourselves, as our stakeholders, by our patients. Simon, I'll get you that PSA safety netting feature. We'll work on that. But anything else, please do let us know. But something like Jess's Law, which is so, so powerful, the first thing that came to my desk, and actually Professor Sir Mike Richards, who we're going to hear from shortly, actually introduced this to me and told me about Jess's Law, is what is the implementation science going to be? Because for every GP in this room, or anyone who works in primary care, the first instinct is going to be actually a pop-up, or to think cancer for anyone who attends 3 times or more, that might just break the system. Like, that's going to increase volume. It's going to be really, really difficult for us to do. And whilst the intention is good, can we feasibly do that? And we get it. But how do we solve that with technology? So I want to show you what we are doing at See the Signs. And when Jess's Rule does get launched, potentially in summer or early autumn, we're really excited to actually launch this across all 1,500 practices using See the Signs when it comes so. But a lot of what we did is, as soon as you launch the patient's record, we assess for cancer risk. We'll give you a pop-up on Jess's Rule, but fundamentally we'll actually show you why they're at risk of cancer. We'll pull through the features and we'll take you straight to a risk assessment. That was super fast, so I'm going to probably show you it again so you can see what that looks like. But again, this patient, let me just go back. Perfect. So patient comes in, you get a real-time pop-up. You learn more, you can see every sign, symptom, and risk factor of why they've triggered, and we can pull that through to make a risk assessment. So 15 seconds, guys, we can tell you if that patient, based on their 3rd presentation, and using AI and NLP for us to pull through their past presentations, we can let you know if it's a cancer presentation, what to do next, and signpost you to a referral form. So this is where we are obsessed with saying, how do we take a problem and create a solution that can work for primary care? And again, if you have any feedback on that, please let us know your feedback if you have any things that we can change. But we're super excited to support this and also to think about how we can prevent people from being diagnosed late. As Mars mentioned, across all our sites, we've actually seen that most people get referred on the 1st or 2nd GP appointment. So again, this is another safety net on how we protect these patients from that respect. I've got a couple minutes left, and I'll just leave here a quote from you, from Mary Curie, one of my heroes. But nothing in life is to be feared, it's only to be understood. And now is the time to understand more so that we may fear less. So thank you so much. Let me know if you have any questions. If any feedback, also just if anyone, we didn't get a chance because Andrea wasn't here, but if anyone has any reflections on what you saw about Jessica, what happened to Jessica Brady as well, feel free if you'd like to just reflect on what you saw and how that made you feel, and kind of maybe the system constraints you're working in. Feel free to put your hand up.
There we go, it just appears. Thank you so much for that. Just a comment, really. I'm so pleased that See the Signs are bringing in this new feature with Jess's Law. I didn't have much time to go into my case of the late-stage cancer diagnosis, but it's always that heart sink moment of that late-stage diagnosis, and then a clinician sits down then to do the case review, and it's the multiple attendances, and it's usually different clinicians, acute appointments, not really joining up, the 2 shortness of breath, the 3 abdominal pains. So I think it's hopefully going to be a game changer for the ones that get missed, because as you said already, most of the See the Signs users are referring early, but yeah, so really pleased that that's coming in.
Thanks, Bushra. Brilliant. Okay, see you then. Thank you.